Ladies and gentlemen, this is chapter 4 from the Merrill's Atlas, Volume 1. We have isolated just the most common procedures here. We're going to circle back around and do decubitus views after we cover this portion here. So this should be, I think this is either week 2 or week 3 that we cover this. This is the abdomen flat projection or supine projection, also known as the KUB, and the abdomen upright projection. So let's get into it. Okay. So our objectives for these or for this lecture is it's gonna follow this basic format all the way through procedures. I'm going to start in the slideshow with an anatomy review. And I say review because you should be covering this stuff in your human structure and function class. So the depth that we do anatomy in procedures class is not the same depth that you cover. You go much deeper in anatomy in human structure and function. We're going to be focusing on gross anatomy or macro anatomy, that is identifying whole organs, so to speak. Now on some of the illustrations, we do dive deep, like parts of the lungs, bronchioles, right and left mainstem bronchus, and alveoli, those type of things. But as far as the abdomen, I want you to know, you don't have to know necessarily left and right lobe of the liver. You have to know that the big gray triangle in the upper right hand corner of the radiograph is the liver. You have to know where the kidneys are. And really the anatomy and the diagrams, I do want you to know that, but it's more important that you know radiographic anatomy. That is, you look at an x-ray of an abdomen, flat plate, KUB, like we see here in this picture. Visit the tanning bed, dude. Just kidding, that's a picture of me. No, I am fair-skinned, but I did not model for Merrill's Atlas. A little bit heavier than that. That might have been me at 16 years of age, but okay. I have a love affair with butter and cheese now. So, okay, moving on. So you should be, as far as the anatomy review is concerned, yes, there's going to be illustrations, but it's more important to identify anatomy on radiographs for procedures class. Okay. We're going to start with illustrations because that's what you're used to in human structure and function. But the skill set you're developing here, as far as anatomy goes, is let's identify it on an X-ray. Okay. General procedure considerations. There are certain things when we perform an X-ray exam that we always do, like change the patient's clothes. The patient shows up oftentimes with clothes, jewelry, and or accessories that get in the way of taking a good radiograph. And so we always have them change clothes, typically, especially for torso work. And then we have breathing instructions, positioning instructions, shielding, things like that. And so there's certain things that we do every time. We have to set up the X-ray tube for the projection. You have to set up the table. You have to dress out the table with clean linen. So those type of things we talk about in general procedure considerations. Okay. And then we get down to the nitty-gritty of how do you position the patient for the supine abdomen projection. How do you aim the X-ray tube and the X-ray beam at the patient correctly to achieve a proper radiograph? How do you do that when they're standing? How do you do that when they're laying down? And then what does a job well done look like, which might be the most important part of the procedure, is confirming that you did it correctly and you've got some kind of diagnostic yield. And then special considerations is going to be certain things that would trip up a novice practitioner that you might not be aware of, or things you're always going to have to adjust for. Okay? Things, most notably, is going to be patient size, because not all patients are the same size, not all patients' abdomens are the same size. And so the power settings on the machine are going to change with changing patient size. You're not going to use the same, it's called technique. You're not going to use the same settings on the machine to x-ray a 4-year-old as you are a grown adult, as you are a heavy set individual or a hypersthetic individual. All right. So let's move on now that we understand how the layout, and this is going to be the layout for most of your procedures lectures, is this same format, going through these, okay, going through these steps. Review the anatomy, general procedure considerations for that particular body part, okay, the specific projections that I want you to learn, okay, and then image quality standards for those projections. Okay. Now, as we get further into the course, we're probably going to do the image quality standards as a separate discussion with the PACS and pull up images from the hospital archive right in the classroom. So one of the benefits of a hospital-based program. All right, so let's start with a review of the anatomy, and this, so that might look like a space alien to you. You might have seen an abdomen x-ray before. You might have seen your own abdomen x-ray before. You might notice that the two radiographs left and right here look similar but different. Okay, well, there were the two radiographs were taken in different ways, and so by the end of this lecture, you're going to be able to recognize one of those is the supine abdomen, the other one is the upright abdomen. Okay. All right, so major anatomical structures: diaphragm, esophagus, stomach, spleen, liver, gallbladder, pancreas. Okay, these should be familiar to you. You might not know the parts of the large colon and the small colon yet, but as you cover the digestive system in structure and function, the right-hand side list will become familiar to you. So cecum, ascending, transverse, descending, sigmoid, and rectum, those are the major sections or parts of the large colon. And then duodenum, jejunum, and ileum are the sections, the three sections of the small bowel. Okay. Duodenum is sometimes pronounced duodenum, depending upon who you listen to. So I've heard it both ways. I'm comfortable saying it both ways. All right, so abdominal pelvic cavity. I do apologize for the gray. It looked better when I built the PowerPoint. Now it's kind of, oh, why did he do that? So there is this same illustration is in chapter 4 of your textbook without the annoying fading gray stripe behind it, if you prefer to look at that. But the illustration is just showing you an anterior view of the major abdominal organs, and where you can, and this is to match up, this illustration is to roughly match up with the radiograph that we're going to look at later. Now, some things will just not show up. Some things show up pretty good, some things not so much. So what does and doesn't show up? The liver is fairly consistent. The liver shows up as a gray triangle in the upper right-hand corner. Okay. The stomach usually has an air bubble in it, so we can see the air bubble in the stomach. Okay. Spleen depends on how large it is. Sometimes it hides behind the stomach and you don't really see it that good. Sometimes it's really obvious. So it's hit or miss with the spleen. Pancreas, you're never going to see a pancreas unless it's being highlighted by contrast, but we'll get to that next year. Okay. Large colon is usually filled with air. Yes, everyone does it. Okay. Yeah, everyone knows where that air goes. Everyone does that. Okay. Some people have manners enough to excuse themselves to the restroom, and then there's boys. All right. So large colon shows up because, again, the air bubbles in it show up, and it kind of frames the lower abdomen. so it's easy to recognize. Um, a small bowel shouldn't have much air contents in it. I mean, you see occasional air bubbles in it, but it's like a mound of spaghetti, so it kind of shows up, but kind of you can't really pick out individual structures. It is self-superimposing, and again, until you fill it with contrast, you don't really see the details of the small bowel well on a plain radiograph. Kidneys do show up on thinner habitus. Okay, so asthenic, hyposthenic, um, and some sthenic, you'll see kidneys. As the patient becomes more larger and larger, the ability to see the kidneys reduce, and that's because the color of the kidneys on the X-ray kind of blends in with the excess adipose tissue, so it gets harder and harder to visualize the kidneys as the patient gets larger. Okay. The other thing that we don't see on this diagram that you will see on KUBs, and it's actually an image quality factor, is you'll see the psoas muscles. The psoas muscles are, if they were on a pig, you'd call them the tenderloin. It kind of holds up the lumbar spine from the anterior. It's not as rigid as the rectus abdominis, but it does play a role in supporting the lumbar spine. Okay. And then all the way at the bottom, the urinary bladder is recognizable on the radiograph too, as well as the bones of the pelvis. Those are also recognizable. All right, so the whole thing, the entire abdominal cavity, is surrounded by a double-walled serous membrane. The serous membrane, it's got fluid in between the two walls, so the two layers of it. There's an outer layer and an inner layer. The outer layer is parietal, kind of sounds like perimeter, okay? And this is similar to what we saw in the thoracic cavity, or what you will hear about in the thoracic cavity, the pleura. Same design, same concept. We want friction-free motion of the organs in the torso versus the cage that houses the torso. So in this case, the abdominal muscle, the lumbar spine, and the bones of the pelvis, we want the organs sliding past them friction-free as we walk around and we breathe. If there's any internal friction, because there is no slippery double-walled membrane, then we get tissue tears from the friction. So the peritoneum and the pleura basically make it so you don't shred your internal organs every time you twitch or take a breath. Okay, very important job. All right. So the inner layer, the visceral is a medical term. You'll hear about medical terminology pertaining to the organ. Okay. So the visceral peritoneum is divided into two special sections, which we're going to talk about on the next slide. And then there's spaces behind the peritoneum. Okay. The space behind the peritoneum is called retro. Retro is prefix, which means in back of or behind. The kidneys and the pancreas are technically not in the abdomen. They're behind the abdominal cavity, and they're in the retroperitoneal space. I believe the aorta is also technically in the retroperitoneal space. All right, so here's a cross-section view of a abdomen that's been sliced laterally, okay, or sliced along the sagittal plane. And it's trying to show you the membranes supporting some of the organs, okay? And you can see the pancreas behind the stomach in the retroperitoneal space, okay? The kidneys would be there too, but they didn't draw them in. Slightly lower than the pancreas and the stomach, okay? Liver sits up top. But I want you to draw your attention to The visceral peritoneum has got two sections. It's got an upper part and a lower part. The upper part shrouds the liver, the stomach, and the transverse colon, and that's called the omentum. Okay? The lower part is called the mesentery. The mesentery typically supports the ascending and descending colon of the large intestine and all the small bowel loops. Okay? Yeah. So those are the omentum and mesenteries are the subsections of the visceral peritoneum. All right, transitioning to general procedure guidelines. All right, so preliminary preparation is not typically administered to acutely ill patients or those with suspected visceral rupture, that is organ rupture, like a ruptured spleen, post-MVA, perforation, or obstruction. Okay, so that's like an emergency KUB. Okay, do your best to remove the artifacts. Changing into a gown, no, let's get the radiograph. Okay, you do want to provide a gown for most, have them change, remove sweep for artifacts, jewelry, necklaces, belly button piercings, nipple piercings, things of that nature. Yes, we have to ask. Yes, the patient can refuse. Just make a note to the radiologist. Patient refused to remove their bling, and let's get on with our day. Okay. Um, you can advise the patient that the presence of their body decoration partially obscures the radiologist's view and affects the ability to make a definitive diagnosis, especially in the case of small cancer tumors. Tiny cancer tumors can be completely obscured by piercings. All right, moving on. So your patient preparation, in most cases, you are going to have your patient change into a gown free of any metal. Okay? If they have pants on, they have to take them off. I say this every year. People can't believe that you have to specify this, but you have to specify. You're going to learn real quick. Tell the patient to leave their underwear on. Yes, I'm serious. You have to specify that. There are so many people that just like to share, if you know what I mean. Okay? So specify that they can leave their underwear on. Okay? Underwire bra, yeah, that's got to come off. The hooks in the back and the underwire show up on x-ray. Sports bras have such tight elastic that they produce extra skin fold artifacts and affect diagnosis. They also have to come off. Okay. Patient preparation for trauma or superstat. Do your best to get the metal out of the way. Just make sure you open up the field and try to get them square. It's more speed is of the essence more than he's sacrificing quality a little bit in the case of visceral rupture, perforation, or obstruction. Okay. Exposure technique I'm going to get into on an upcoming slide. Going to expand on that, as well as all the rest of that stuff. And so let's get on with it. All right. So exposure technique. The book recommends 85 for sthenic habitus. Now, what does that mean? Well, sthenic habitus means normal body habitus. So you're looking at an adult patient that weighs somewhere between 130 and 150 pounds. That's sthenic habitus. Okay. Average height, average build. Okay. So how do you know that you use the correct technique? You're going to see all these structures in your KUB, and they all happen to be highlighted here. So the first dashed line on the upper right, that's the lower border of the liver. The psoas muscles look like Morse code. It's the alternating dots and dashes. Kind of looks like tent canvas around the lumbar spine. Okay. The kidneys are the dotted lines that are bean shaped, and there's two of them, one on the right side underneath the liver and one on the left side about an inch and a half, 2 inches higher. And yes, that's a registry question. And then the transverse process of the lumbar vertebrae, that's kind of hard to see on this radiograph, but there's little bony projections sticking out into the psoas muscles to each side of the lumbar vertebrae. I'll definitely point them out to you either in lab or in image critique. I'll show you where those transverse processes are if you can't make them out here. Okay. Adjustments to technique for habitus and pathology. So we started out with a baseline of about 85 for our average patient. Our average patient is going to measure from, and this is from anterior to posterior, about 12 to 14 inches thick. Okay. And then you can see the different gradations of habitus or body part size correspond with the different measurements. So when I say asthenic, hyposthenic, that's always less than average. Hypersthenic is always more than average. Okay. And so what we want to hammer home and what we want to get you guys comfortable with is probably the hardest thing to wrap your head around about x-rays. And that is, what are the power settings on the machine for? What is the technique? Okay. So technique is what technologists refer to as kVp and mass. It's literally the electricity settings, the quantity and quality of electricity that you're sending through your x-ray machine. Okay. The mass is the quantity, and it's literally how many photons are you making? How many x-ray photons are you making? And then the kVp is the energy or the quality. How penetrative are those photons? How much can they punch through before they stop? Like solid matter. Okay. And for the extent of x-ray science, a human body is considered a solid object, even though it's ultrasound techs would say no, it's a liquid. But yeah, we're both kind of right. Okay. For x-ray purposes, the human body is a solid. Okay. A solid of varying densities or mass per unit volume. So bones have more mass per unit volume than muscles do, than adipose tissue. So different tissue types have different tissue densities. Okay. And so that affects how the radiograph looks. It affects how efficient the kVp is at penetrating. Okay. Bone, because it has increased tissue density, is one of the most difficult things for the x-ray to penetrate. Okay. The other thing that affects selection of technique is pathology, the presence of pathology. So pathologies can be additive or destructive, okay, and can adversely affect tissue densities. For example, ileus, which is small bowel obstruction, usually involves gaseous expansion, abnormal gaseous volume of the small bowel. And so there's a lot more gas in the abdominal cavity than there usually is. Well, bowel gas is air, and it's one of the easiest tissues to penetrate. And so if you're swollen up with air because you're obstructed, the x-ray tech actually needs to reduce the kVp when you have small bowel obstruction, ileus. Okay. The opposite of that, when would you need to increase technique for pathology? What's an additive pathology? That would be a condition called ascites. Ascites is when you draw fluid to your peritoneal cavity, excess fluid to your peritoneal cavity. So now the X-ray beam is trying to go through the organs plus like an extra jug of water. Almost if you set a milk jug full of water on top of the abdomen and try to shoot through both of those. So ascites is adding a volume of water to the X-ray beam. Okay. Well, it's harder to get through than just the tissue, just the normal tissue itself. Those water molecules impede the progress of the X-ray beam, and you need more penetration and you need more photons. And so not only do we adjust the kVp and the mass, that is the penetrability and the number of photons we send, according to the size of the patient, but we also change it up and adjust it dependent upon what their backstory is, what their history is, and if they have a known pathology or a known, especially if it's known to be additive or destructive, you're going to need to change technique for that. All right. SID. What the heck is SID? Well, we did cover it in the chest PA and lateral lecture that you should have already listened to. Okay? But it stands for source to image receptor distance. Source of what? X radiation. So that's our X-ray tube. That's our machine. It's blasting out this radiation in a beam. Okay? Very similar to a flashlight. Okay? Except you can't see the components of the beam like you can with a flashlight. You can't. It's not visible to the human eye. Okay? So we set this at 40 inches for most projections, and what's happening is the beam is expanding. Okay? As the beam travels through the room, it kind of grows in size. It does grow in size. The beam is in the shape of an expanding pyramid. Okay? And so you have to visualize that in order to really understand where you're shining that flashlight. You have to imagine the expanding pyramid of the flashlight beam, the X-ray beam. Okay? So we set about 40 inches as the minimum distance to allow for the beam to spread out and cover the entire image receptor. If we go shorter than that, we're not going to be able to open up the X-ray beam to see all the anatomy for the larger projections. Okay? We're also going to overdose the patient if we go shorter than 40 inches. Okay? Because we're going to find that the intensity of the radiation is inversely related to the square of the distance from the source. Okay? We're going to cover that in the radiation protection introduction chapter. Okay? The exception to the rule for the 40-inch standardized SID is for any projections that require a large OID, an object to image receptor distance. Now you notice in this illustration, the patient has their back right up against the image receptor, which is running vertically in this projection, or this illustration. Okay? So that's what we call zero OID. For all zero OID projections, you can take this to the bank. For all zero OID projections, the correct SID, or the recommended SID, is 40 inches. Okay? Now, how do we know we're at 40 inches between the image receptor and the X-ray machine? Well, it depends on when your X-ray machine was built. In the modern era, we have laser rangefinders on some of the fancier machines. The servo motor software basically tracks the position of both the image receptor and the X-ray tube in the machine and can just spit that out. It knows exactly when it's 40 inches. It will actually put itself in position at 40 inches to the image receptor if you set it up correctly. We'll show you that fanciness when we get to the, well, you should have already seen it in the equipment manipulation lab. Okay. Very old school, there is an embedded tape measure in the collimator, which is the box out front there with the orange and the red buttons on it that you see in the illustration. So um, there is a tape measure embedded in some of the old collimators, especially if they don't have the laser rangefinder or the servo motor software reported SID. Okay. But we have to have this at 40 inches before we can proceed. Modern equipment also has exposure lockouts for abnormal SIDs. So if you're not at 40 or 72, which is the exception for the large OIDs, your modern X-ray equipment sometimes doesn't let you expose. It disables the generator and the exposure switch to correct the error. So always. Sorry about that, guys. Every time I record one of these lectures, it never fails. You can ask the seniors, the phone rings. My phone doesn't ring until I start doing the recordings. So it's uncanny. I've been doing this for 3 years, maybe even 4 years. And every time I try to do a recording, the phone rings. All right. Sorry about that. I do try to pause it so that you don't miss any information with the sound of the phone ringing. Okay. Some of the seniors say that I swear on one of these things too when the phone rings, because it rings like 3 times in one of the recordings. So something for you to look forward to. All right. The abdomen supine, the technologist is going to call it a KUB. That stands for kidneys, ureters, bladder, which is the critical anatomy that needs to be revealed on this projection. Okay. We need all the bladder, both the ureters, and both kidneys. All right. So we start with the patient position. The patient needs to be supine. That means recumbent, laying down, with the anterior side facing up towards the ceiling. That is laying on their back. Okay. Now, your older folks and some of your younger folks laying down on a table is not going to be comfortable. Okay. If your patient's uncomfortable, they're going to move and shift so that they do get comfortable. That usually means rotation of the part. So we make them comfortable. You're going to take either a pillow or a rolled up flat sheet or a 45-degree angle sponge, like a positioning sponge, and allow them to bend their knees and flex their knees and put a support sponge underneath their knees. That's going to reduce lumbar strain and it's going to make them more comfortable. Okay? It does not affect image quality. The image receptor is going to be aligned to the level of the iliac crest, and then the central ray intersects the level of the iliac crest at the mid-sagittal plane. Okay? The central ray is directed straight down toward the floor. That is a plumb line perpendicular to the image receptor. So long as the floor and the table are level, then the X-ray tube should be directed so that the beam is heading toward the floor in a perfect 90-degree angle to both the floor and the image receptor that you've placed inside the table. Okay? So you're working inside the table bucky with your image receptor. Okay? Right or left side markers are placed. Typically, you're placing a right marker in the area of the patient's right hip, the bottom outside corner of the image receptor. Okay? You'll not reach across and place your marker on the far side of the image receptor. That's a good way for the table to eat your marker and not give it back to you. Okay? Avoid using digital annotation to place side markers on images. Okay? So post-processing annotation for left and right side markers does not meet the legal standard for radiographic image marking. That's why we make you buy X-ray markers with your initials on them, because that is the legal standard for radiographs. Every radiograph you take in clinical education and for the rest of your career should be annotated with radiopaque markers. Other ID markers must be on the final image. That has to do with the exam details. They should match what you understand is your patient. So your patient will have a unique name, date of birth, medical record number, and exam accession number. Those details should be stamped on the corner of your images as you send them to PACS. That is, assigning the images to the correct exam and the correct patient. Your text will explain how that happens. We will get to it in our senior year, but you'll know it by then. Shielding is updated, the latest and greatest from our fraternal organizations and our governing bodies. Shielding is not recommended for abdominal pelvic radiography, and that is to say, shielding of the gonadal organs cannot be done typically with abdominal pelvic radiography without superimposing and obscuring, therefore, tissue that was supposed to be evaluated by the radiographic study, right? So the contents of the bony pelvis on both abdomen KUBs and also pelvis radiographs can't be covered up by a shield. The whole point of taking the radiograph is so the radiologist can see that anatomy. And so it's typically not possible to shield reproductive organs and not clip the anatomy when you place the shield. Okay, it can be done for a male, but you have to be very, very specific with your shield placement. Sorry, got interrupted again. All right. I think I got through. Now, body habitus considerations, again, for our larger patients, 2 crosswise projections. Tall patients, like myself, you might need just a 10 by 12 extension rather than a whole separate upper and lower crosswise. Okay. But our hypercenic patients, it's actually more common when we x-ray abdomens to do an upper abdomen crosswise, lower abdomen crosswise than we would do a KUB like this. And I'll show you both in positioning lab. All right, for our upright abdomen, the point of the upright abdomen is the diaphragm and any free air, peritoneal air, that might be trapped underneath it. So we want our patients standing, and typically we don't want them like immediately standing and shoot. We want them standing, get them into position. Kind of, I think the recommendation is 4 to 5 minutes. I'll have to check that to be sure, but you want them standing for a bit of time, so if they do have that free air, it does migrate up to the very top, up under the diaphragm, and creates a little black crescent moon sign in between the diaphragm and the organs of the abdomen. So have them stand with their back facing the vertical grid device. It's called the Bucky, again called the Bucky. So the Bucky Potter diaphragm was the original cassette holder way back in the day. I think it was invented in the 19 teens, like 1915 or somewhere around there. Okay, and we've been using it to hold the image receptor cassette ever since. And so there's a vertical one for standing radiographs, and then there's one embedded in the table for laying down radiographs. Okay, you can also x-ray with the image receptor right there on top of the table. We usually do that for extremity work. Okay, so we're putting the image receptor in the vertical Bucky device. Again, the mid-sagittal plane is centered to our image receptor. But this time we're going to raise that centering point up 2 inches from the level of the iliac crest. Okay, and the reason is we want to catch the diaphragm. The diaphragm is more important on this projection than the regular KUB projection. The regular KUB projection is visualization of the organs of the lower abdomen and the pelvis. This projection is for visualization of free air in the peritoneum. Okay, and so we center 2 inches superior to the iliac crest at the mid-sagittal plane. Get them nice and centered. Again, don't let them rotate. A good indicator for rotation is the ASIS should be the same distance to the image receptor. One shouldn't be higher up than the other. Okay, same thing when they're laying down. The ASIS, the pelvis should be symmetric. ASIS on both sides should be the same height off the table. All right, so where do we center again? For the upright projections, where do we center? Yes, that's right. It's choice A. We're going to center at 2 inches above the iliac crest, or 5 centimeters. They are starting to introduce metric measurements and roll us into complete metric measurements for the credentialing exam. And so we got to start talking about positioning and positioning landmarks as certain distances in centimeters from your positioning landmarks that you learned in chapter 2. Okay. All right, so this is the end result of the abdomen flat plate, the KUB, the abdomen supine. Okay. And so what I can see here, I'm going to start in the upper right-hand corner. There's ribs there, and those ribs are striped over a triangle-shaped object that it's all basically one color gray. You can see the bottom end of the triangle is kind of pointing at that small letter R in the right middle border. Okay, so that little corner, that little point of the triangle, that's the bottom corner of the liver. Okay, it kind of tracks with that 11th rib there. Kind of runs parallel to that 11th rib. And as you get closer to the midline, it's kind of hard to see that lower border of the liver, but it is there. When we get to the packs, if I find a good one, I'll zoom it up and you'll be able to see the lower margin of the liver really clearly. Okay. There in the middle of the top of the radiograph, that of course is the spine. That's the thoracic spine. And so that might be rib 12 rather than rib 11. I might have mislabeled that. Yeah, that's rib 12. So that's vertebral body 12. That's all basically solid white there. Okay. And then you can see the air in the stomach crossing the spine at L1. Okay, and so you can see the stomach shape there as an air bubble. Okay, the spleen, we just know by difference, is to the far left, so in the upper left-hand corner. That gray color that matches the gray color of the liver, that's the spleen. Okay. Now moving downwards, go back to L1, lumbar spine, or lumbar vertebrae number 1. So you see the bright white one, the one just below that, the ice cube shape, the rough ice cube shape, just below that. You see the two tent canvas lines coming off of that? That's the border of the psoas muscle. And now on the right side, in between the lower border of the liver and the psoas muscle border, you should see a bean shape. That bean shape, and if you can't make it out, the kidneys are probably the hardest thing to make out on a KUB. It takes a real learned eye. You have to practice looking for it, so to speak. Hang on just a second. Uncanny. All right. So, yeah, there's the kidney bean shape in between the psoas muscle and the lower border of the liver. The other kidney bean shape, or the other kidney, all right, so there's a giant air bubble in the middle of the right kidney. I think everyone can see that, okay? If you start with a small letter R and you go straight over horizontal, that intersects the bottom of the kidney, okay? Go up and it kind of, I don't know, it kind of looks like a horseshoe shape, or maybe a helmet, like a cracked helmet shape, this air bubble that I'm talking about. Y'all see that? That kind of looks like a cracked helmet, like a helmet got split or something. Okay, so from that big giant air bubble, go across the spine past the other psoas muscle. You are now at the bottom of the left kidney. Okay, and so the left kidney, track it back up. You see there's two lines tracking back up at, toward T12L1. The inside line is the left psoas muscle. That outside line is the border of the left kidney. Okay, and so you can see a rough bean shape. If you keep following that line around, you can see a bean shape on that left side. It's actually easier to see the left kidney on this radiograph than the right one. The right one is always crowded by the liver, and it makes it harder to make out. But you can see both of them. That gas bubble isn't the helmet-shaped gas bubble isn't doing us any favors though. Okay. All right. Moving down into the pelvis, we can see both wings of the pelvis. Those are called the ilia. Okay. Um, Sacroiliac joints, the sacrum in the center. See how the sacrum looks symmetric, and the but the right side of the pelvis looks skinnier than the left side of the pelvis. That's slight rotation. It's just noticeable. It's about a half a degree of rotation, but it is some slight rotation here in this radiograph. Now, is it enough to repeat? No, it's not. But there is. So kudos to you. If you see that pelvis is slightly asymmetric, you have a good critical eye. Okay, so the width of the wing of the right pelvis is a little bit skinnier than the width of the wing of the left pelvis. Okay. Uh, Track back to the middle of the radiograph. Look at the lumbar spine. Okay. And you're going to see like some ice cube shapes. Those are vertebral bodies. And then superimposed over that, there's going to be like a vertical dashed line of bone. Those are the spinous processes. Okay. Now, I like to call that the angry emu sign, and I'll show you that coming up. But that is a sign that your lumbar spine is not rotated. If those spinous processes are centered, that is the vertical dashed line of bone is centered on the ice cubes shapes, well, then your lumbar spine is not rotated. Okay. So let's go into this in words, shall we? All right. So, image quality standards and image critique. Did we do a good job with our radiograph? Proper collimation. What does that mean? Well, we need the pubic symphysis on the KUB, the abdomen supine radiograph. Okay. We need the diaphragm on the upright radiograph. Okay. Now, do you need the diaphragm on the supine? It really depends on your facility. Okay. It depends on facility protocol. Most places, a KUB, if you have all the kidneys and then you have all the bladder and the pubic symphysis, you're good. Okay. Some places they're like, no, an abdomen supine is from diaphragm to pubic symphysis. So you got to kind of clarify and ask on the front end, what's the protocol? Do we need stem to stern, or do we only need to get up to the top of the kidneys? Okay. For the upright projection, sometimes it's all the way to the pubic symphysis, sometimes it's diaphragm and as much of the anatomy as you can include inferior to the diaphragm, but don't clip off any of the diaphragm. Okay. Proper alignment and rotation indications. Okay. I will go over these separately in an image critique session. Okay. But we're looking for symmetric presentation of the rib cage, symmetric presentation of the pelvis, that is, the left side of the pelvis and the right side of the pelvis look like mirror images of each other. Spinous processes centered to vertebral bodies. That's the dashed bony line centered to the ice cubes. Okay. Visible organ borders and lateral abdominal wall, which I did not show you. If we can see it on the upright, which is coming up in the next slide, I'll point that out to you. Psoas muscles visible. Okay. Organ borders and psoas muscle outlines start disappearing with hypersonic habitus. So the larger your patient is, the less of the soft tissue details you are able to visualize. Okay. Air fluid levels present on the upright projection, and that's how I was able to tell the difference between the upright and the supine radiograph on the very first slide in this PowerPoint. So let me show you that quick. This is an upright. I can tell it's an upright because, first of all, we've clipped the pubic symphysis, so it's not a proper KUB. Second of all, we've got the entire diaphragm. Third, the black arrows. You see the horizontal lines there? You see they're at the bottoms of air bubbles? Okay? That is an air fluid boundary. A chemist looking at a beaker or a graduated cylinder would call that a meniscus. It's an air fluid boundary. Okay? Air fluid boundaries are going to show up just like they do in visible light. Like if you're in chemistry and you want 100 milliliters, you pour the fluid into the graduated cylinder and you read the meniscus. Okay? You read the air fluid boundary. Okay? On a radiograph, the air fluid boundary also shows up with an X-ray flashlight. So in chemistry, you're reading like the refraction of the light coming off the meniscus. That's how you can identify that meniscus. Well, you can see the air fluid boundary with X-ray light too, okay, inside a patient. So that's what we're seeing with this horizontal line. We're not really seeing refraction so much as we're seeing a difference in absorption between liquid material, water-based, hopefully, and air tissue material, that is air bubbles in the colon. Okay, there's a huge difference in the absorption of X-rays between air and liquid, and that distinction shows up as a horizontal line whenever you shoot with a horizontal X-ray beam, like in an upright abdomen projection. Okay. And so we always see this meniscus sign that always tells us that this is the upright. Now, it is not nice to confuse your radiologist. You should always label your upright projections upright, either with an arrow next to your marker or the words upright typed in next to your marker. Okay? So that it's crystal clear to the radiologist. They will know, but they appreciate you clarifying that this is the upright projection. Okay? Sometimes patients don't have air fluid. They don't have air bubbles in their bowels for whatever reason. And there's not an appreciable amount of air fluid level signs. The meniscus sign is not as dominant as it is in this radiograph. And so sometimes the radiologists do need the label. All right, special considerations. Sometimes our patient can't stand up. All right. So when our patient can't stand up, but they've ordered an upright abdomen, we're going to do a decubitus view. Now, what the hell is a decubitus view? I'm going to teach you that next time. Okay. Remember that the technique should be scaled to habitus or part thickness. You don't use the same power settings for the x-ray beam on a child that you do for a 300-pound man. Okay? The nature of the beam and how it behaves is determined by the technique settings, the KVP and mass. A prone abdomen reduces superimposition. We didn't talk about this, but Mr. Shepard wanted me to mention it, so I am. And part thickness. We are actually compressing the abdominal tissue when we make them lay prone. And so we can actually reduce dose if we do prone KUBs rather than supine KUBs. The abdomen may be radiographed in 2 parts for larger patients. It might even be radiographed in 4 parts. Yes, I've done quadrant radiographs. Right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. 4 exposures, 1 abdomen. Yes, it does happen. When we get longer exposure times in our abdomen radiography, we cannot control peristaltic motion. It's involuntary. Peristaltic motion is the motion of the gut, the small bowel, and the large bowel, and the stomach. It's automatic. So the way to avoid excessive peristaltic motion is keep the exposure time short. Okay. All right. That's it. Nuts and bolts you guys know how to do, or you have at least been explained how to do the dominant 2 projections for the abdomen, the supine abdomen and the upright abdomen. Okay. And so you've listened to this before lab day. And so you already understand the description. As you've listened to this, you've flipped along in your atlas and followed along with what I've pointed out, and you're ready for lab, and therefore it's not going to sound like Klingon or Romulan or any other alien language to you. You're going to pick up what I'm putting down when I go through it in laboratory demonstration. All right. See you guys next time.